Well, welcome and thank you for listening in. The title of my presentation is Laboratory Diagnosis of Cushing Syndrome for Primary Care Physicians. My name is Hershel Raff. I'm a professor at the Medical College of Wisconsin in Milwaukee, Wisconsin, United States of America. I have no disclosures relevant to today's presentation. So as a clinical physiologist, I always start out with a tiny bit of physiology to remind you back when you were in school. This is called the HPA axis, or the hypothalamic pituitary adrenal axis, and it's a classic pituitary feedback loop system. There's inputs into the hypothalamus in the brain, and most of these are called stress inputs, like emotion or trauma, pain, blood pressure, blood gases, things like that. There's also a non-stress input called the drive to circadian rhythm that everybody with a diurnal lifestyle has. And I'll come back to that in a little while because it'll become very important. CRH from the hypothalamus through the portal vein stimulates the anterior pituitary gland to make this very interesting hormone ACTH. The T could stand for two different things. Tropic, which means a very quick response where it stimulates the adrenal gland to have a burst of cortisol release, or trophic, which is the growth promoting effects of the adrenal gland. When ACTH is high, the adrenal gland hypertrophies, and when ACTH is low, over time, it atrophies. And then the last feature, maybe the most important, is negative feedback, where cortisol limits its own release by inhibiting CRH and ACTH release. Again, this is the classic hypothalamic pituitary target gland negative feedback system. So what I'm going to focus on today is spontaneous Cushing syndrome. Now, we're trying to get away from eponymic names for a variety of reasons. And as you will see, one reason is people's image in their mind of what Cushing syndrome is very different than what we really see. So we have developed a different definition that's more functional and doesn't require knowing who Harvey Cushing was, called neoplastic hypercortisolism. That means hypercortisolism, too much cortisol from the adrenal gland due to an ACTH secreting tumor or a cortisol secreting neoplasm. Of course, exogenous Cushing syndrome or iatrogenic Cushing syndrome is much more common, and that's due to any pharmacologic dose of glucocorticoid, for example, prednisone given to a transplant patient. But the route of the glucocorticoid doesn't really matter. It could be intraarticular, epidural, inhaled. There are even reports of babies given a very potent steroid cream on diaper rash causing iatrogenic Cushing. So there is no safe glucocorticoid, particularly with a high dose over long periods of time. Now, although this isn't relevant to the screening diagnosis of Cushing's that we're going to talk about, I always feel obligated to explain the pathophysiology. There's ACTH-dependent Cushing's, much more commonly due to a pituitary tumor making too much ACTH. That has got the specific eponymic name Cushing's disease. And what happens is the tumor loses sensitivity to glucocorticoid negative feedback. It still has some, but it's less than a normal ACTH secreting cell, so that this cortisol that goes up as a result of the high ACTH can't bring the system back to normal. Much more rarely are neuroendocrine tumors, for example, of the lung or the ovary or the islet cells in the pancreas, can make ACTH. Again, this is fairly rare, but the end result is the same. Increased ACTH, increased cortisol, and the disease. Then there's ACTH-independent Cushing, where there's an adrenal tumor, typically benign, autonomously making cortisol and thereby suppressing ACTH. But because the tumor is a tumor, it keeps making cortisol in the absence of ACTH. Now, if there's one take-home message here, is that unlike what we learned in our training, Cushing syndrome is not rare. It's unusual, but it's not rare. Up to 8% of patients with resistant hypertension, that is, you're giving 2 or 3 antihypertensives and the patient's still not under control. Up to 3% of poorly controlled or newly diagnosed diabetes. And in fact, there's now a clinical trial going on that suggests that because we're better at finding Cushing, it's much more common than that. They're estimating somewhere between 10 and 20% of these patients may harbor a neoplastic tumor, either making ACTH or cortisol. Now, this intriguing study said that 7% of patients with the combination of obesity, type 2 diabetes, and hypertension can have Cushing. And what's the bottom line here? We have to be missing a lot of patients with this curable disease. A lot of emergency rooms now have CT scans. So somebody comes in with a bellyache, they do a CT scan and they find these incidental adrenal masses. They're called incidentalomas. And not surprisingly, these tumors can make cortisol. Another intriguing study, this one from Italy, showed that osteoporosis, particularly if you can't explain it, and vertebral fractures and also maybe rib fractures can have undiagnosed Cushing. And we have experienced this in our bone clinic. Now, what is also clear is just screening anybody with obesity is probably not worth its while. There are a couple of exceptions to this. One I'll show you in a little while, but the most important is in our bariatric surgery program, everybody is screened for Cushing's because it's so easy and inexpensive to do compared to the surgery. Because if a patient has hypercortisolism, the surgery will not work. It just doesn't work in somebody with Cushing syndrome. So the clinical features of Cushing are so varied, we sometimes call it the protean disease. That is, the Greek god Proteus could take any form. And we've had patients with just 1 or 2 of these findings. But think about how common this is. Obesity, hypertension, diabetes, hyperlipidemia. We'll come back to growth retardation in a second. And hirsutism and acne. Hirsutism in women, obviously. In children, although Cushing is rare, you just don't want to miss it because it can cause growth retardation because glucocorticoids inhibit growth hormone release. Muscle weakness, osteopenia, these are all incredibly common in a primary care clinic. A lot of neuropsychiatric effects of cortisol excess. Gonadal dysfunction. These are all common in our population, and combinations of them are of concern. So in the textbook that you used when you went to school, and I used when I went to school, this is what Cushing syndrome looked like. The fact of the matter is, it doesn't matter what blood test or urine test or whatever test you do, they're all going to be positive. As I tease my students, a first-year medical student could make this diagnosis. The problem is that most patients don't look anything like this. Most patients are much more subtle, like any disease. And this is from a series of patients that Lynette Neiman generated at the NIH, one of the big names in this field and a close collaborator. Nobody would ever guess, just looking at this picture, this patient could have Cushing syndrome. But she did, surgically proven. And Lynette has a whole series of these patients. So what do you do? Well, you certainly don't screen everybody, but there's certain things that can give you a hint. If they have multiple combinations of the symptoms I showed on the previous slide, like diabetes, hypertension, obesity, specific proximal myopathy that's unexplained, the odds ratio is 6-fold, 18 for multiple symptoms, 6-fold for straight myopathy. Osteoporosis about 4-fold. Metabolic syndrome, not surprisingly, about 3-fold increase. And anybody with a lump or a bump on their adrenal deserves to be worked up. Again, what is clear is that just run of the mill, if there is such a thing, obesity, is probably not an enriched population. Now, my clinical colleague, Dr. James Findling, came up with this quote: if you've never missed the diagnosis of Cushing syndrome, you should refer your patient with suspected hypercortisolism to someone who has. And in our Cushing's clinic, we've seen literally thousands of patients, and sometimes even the best informed endocrinologist misses this diagnosis. So this is the guidelines that were published by the Endocrine Society in 2008. They were since updated in 2021 and published in Lancet Endocrinology, and I'll mention that at the end. These are the common tests now for the diagnosis of neoplastic hypercortisolism. The first is late night cortisol. I already showed you the circadian rhythm. I'm going to show you another slide in a minute. But basically, the physiological principle is that cortisol secretion does not reach its circadian nadir, regardless of the cause of the disease. They can still have a rhythm. It just doesn't achieve the bottom, the lowest point at bedtime or midnight. The low dose dexamethasone suppression test, I'm sure you've all used it, learned about it in school. The physiological principle is different. It's a decreased sensitivity to glucocorticoid negative feedback. And the 24-hour urine-free cortisol, commonly done, it's actually the worst by far of these three tests, measures the filtered load of free cortisol in the blood. The nice thing about these three tests is that they assess different physiological aspects of the disease. So if one approach misses the patient, maybe the other one will pick it up. So here's the circadian rhythm I showed you before. That patient with the very, very severe Cushing, that's what they look like. It doesn't matter what you do. They're all going to be abnormal. But the most common patients we see now don't look anything like that. They look much more like this. They still have a circadian rhythm, but their late night cortisol level in the blood is elevated. So how do we know that? We know that because, again, Lynette Neiman's group at the NIH did a massive study where they had surgically proven patients with endogenous Cushing syndrome. And don't worry about what pseudo-Cushing is. We're trying to get away from that term. It's kind of a meaningless term. But patients with maybe physiological hypercortisolism or just look like they have Cushing's are over here. And notice about 95% of all of the subjects with surgically proven Cushing's had an elevated midnight serum cortisol. In fact, the sensitivity and specificity was somewhere between 95 and 97%, which in our world, in Cushing syndrome, that's pretty darn good. It doesn't really get much better than that. Great, fantastic, problem solved. The problem is, how does one obtain a late night unstressed serum cortisol sample in any circumstance, but particularly in primary care? There is no way to do it that makes any kind of sense, either efficient in terms of efficiency or accuracy. It turns out, however, if you remember way back when you learned about this stuff in school, steroid hormones circulate in the blood bound to carrier proteins, as do thyroid hormone. About 95% of the cortisol is bound up by plasma protein, mostly CBG, corticosteroid binding globulin. So only 5% is actually free and filtered in the kidney. That now can give you an idea about somebody with this mild elevation in cortisol over the day, why their urine-free cortisol won't be elevated, because it's just not enough to pick up. But plasma-free cortisol, which is the bioavailable form of cortisol that can bind to the glucocorticoid and mineralocorticoid receptors in the tissues, is reflected in the saliva. In fact, they're in equilibrium. So that when plasma-free cortisol goes up, saliva cortisol goes up. And saliva is really easy to sample. And here's how we do it. There's other ways of doing it. You can just spit in a tube too. That's kind of disgusting. But what we use is a salivette, a very, very inexpensive thing. I think it costs about 40 cents for the whole tube. I mean, the mail sending it in costs more than the tube. And here it is busted up, but basically this cotton swab is just like what the dentist uses. They put it between your cheek and gum or underneath your tongue, and it soaks up the saliva. It takes a minute or two, not very much time. Then when this thing is put in a centrifuge, the salivette, it wrings the saliva out of the cotton and it collects in the bottom right there. And we can measure cortisol, we can measure all kinds of things in the saliva, mostly steroid hormones, but other things as well. But we're just talking about cortisol today. So we did a study. I can't believe it's almost 25 years ago that we published it. Time does fly. And in fact, cutting right to the chase here, the data looked exactly the same as Lynette Neiman's study with blood. Exactly the same. We now do it at bedtime. We don't have a set time. We do it at the patient's normal bedtime. But the concept is the same. Here are the normal subjects. Here are the patients that look like they had Cushing but didn't. And here are the patients with surgically proven Cushing's. And I circle these because, like any endocrine test, unfortunately, there's always a false negative. And we now know what causes this. These tumors that make small amounts of ACTH and cortisol can be intermittent. They're on today, they're off tomorrow. They're on a little more the next day. So we just do a few of these salivary samples in a row. And by the way, this tube we put in a mailer and the patient just mails it back to us. Steroids are extremely stable compounds. And we've mailed it, people have mailed it from all over the country and even Canada. Doesn't matter how hot or cold it is outside. In fact, one of the samples took 10 days to get to us, and we were worried that it wasn't correct. So we got another one, they were the same. So it's steroids. One of the good things about steroids is that they're incredibly stable. So the patient just mails this in. They sample at home at bedtime, put it in an envelope, mail it. It couldn't be simpler. Now, you might ask, why am I bringing up kidney disease? It's incredibly common, as you know, but this is the question I get most often as the clinical laboratorian. What do I do about salivary cortisol if I have a patient with renal failure who I think may have Cushing's? And in fact, they're very similar in their presentation sometimes. Well, interpreting results from the dexamethasone suppression test is a problem because cortisol metabolism is changed. What's the right cutoff to use? Do we use 2 micrograms per deciliter? Do we use 3? There was a study recently published that suggested there may be a way to have EGFR adjusted cutoffs for the DST, but the data are very good, but there's not enough numbers yet to be sure that it's correct. And obviously, urine-free cortisol is not a valid measurement in somebody with a renal failure, particularly if they're anuric, but even if they're making some urine, there's really no way to use urine-free cortisol. But even in a healthy person and in a person with normal renal failure, it's not a very good test anyway, so we just don't do it. However, there is a small increase in late-night salivary cortisol in patients with renal failure, not because of the change in metabolism, but because they lead such an incredibly stressful lifestyle. And I went to visit the dialysis center across the street from my laboratory and just watched what these patients go through every day, every other day, I should say. And a lot of them have lost their jobs. They can't sleep at night. They have sleep apnea. They have all these other problems. Plus, they're getting hemodialysis every other day. And so they have a non-neoplastic form of hypercortisolism, but most of them still have a circadian rhythm. So what we found in our studies is that if the late night salivary cortisol is normal in a patient with CKD, you've eliminated the disease just as if they had normal renal function. If it's a little elevated or very elevated, it requires some thought. And those are the patients that typically get referred to our endocrinologist, who's an expert on Cushing syndrome. So the question is, oh, salivary cortisol, never heard of it, don't know anything about it. Sounds like it's a real pain. It couldn't be simpler. Every reference lab, and I imagine that your laboratory uses at least one, if not more, of these reference labs. These are the 3 biggies that our laboratory uses, and they all measure salivary cortisol. In fact, they do it by the most modern method. The way I do it is liquid chromatography mass spectrometry. So you order it, give the patient the salivary samplers. They do the saliva sampling at midnight, usually 2 nights in a row. Send the samples in. Some of the patients like to drive them to the lab, fine, whatever. If the lab doesn't do the test, which they may, if your hospital lab doesn't do it, they'll just send it to one of these labs who do a fabulous job of measuring salivary cortisol. It couldn't be simpler. So here's my opinion. This is my opinion. It's not exactly what you might find in the guidelines, but this is what I teach my students. The simplest thing to do is just do 2 late night salivary cortisols in a row. So Tuesday night and Wednesday night. And some patients say, could I do it Tuesday night and Thursday night? Sure, fine, whatever. Repeat it if it's kind of, it's a little on the high side. We've had a lot of people right on the edge of the reference range, but the doctor's pretty convinced that they have something. So do it another time or wait a couple of months. And often that false negative will become positive. And we always do a confirmatory test, and we do DST because it's the best of the others. We 24-hour urine-free cortisol is particularly bad for milder Cushing's, as I already explained. But if it's elevated, it's very useful. Very few false positives. About a third of our patients have a false negative urine-free cortisol. Some endocrinologists have told me it's more, depending on the patient mix. So it couldn't be really much simpler than this, could it? So in summary, late night salivary cortisol, you can order it in your lab. I'm sure that your lab can do it, is the easiest and probably the most reliable, certainly the easiest. You don't have to have your blood drawn. You have to take dexamethasone. You don't have to collect your urine for 24 hours to screen for Cushing syndrome. And I'm happy to say, people tell me, oh, you invented this test. Actually, it was invented in 1960. It just never caught on until Dr. Finling and I started doing it, and it wound up in the guidelines. And this is the newer, updated guidelines, Maria Flesserio in Lancet Diabetes Endocrinology in 2021. I was very fortunate to be the lab guy involved with this. It was a great experience. Of course, I'm not a management person. I'm a diagnosis person, so that part I had nothing to do with. Um, but it's a phenomenal article, and I actually have my first year medical students read it in our small groups, and they love it. Of course, it's some of it's pretty esoteric, but it's very well done. And so they agree that salivary cortisol, the DST, are probably the two best tests to do. Yeah, urine-free cortisol, fine. It's not going to hurt anything. But if it's not elevated, don't get discouraged. In fact, the guidelines say it should be at least 2 to 3 times higher than normal before you even get upset about it. So there you go. So it's been a real pleasure giving you this presentation. If you have any questions, I'm sure you can get in contact me through the company that's doing this recording. Thank you very much.